Get to the top of the hour and we'll go ahead and get started. But I hope everybody had a good weekend and holiday celebrating our veterans. All right, we are at the top of the hour, so we can go ahead and get started. So my name is Shamia or Mia. I am the Interim Viral Hepatitis Program Director with the Tennessee Department of Health, and I will be your facilitator for today. Today's agenda will include some introductions and announcements, a didactic presentation on hepatitis C treatment in persons who use drugs and/or alcohol by Dr. Clark Allen. We will do an adult case presentation, some Q&A, and then short closing remarks. First, some in-chat introductions as well as some brief announcements. Before we get started, I would like everyone to take a second to introduce yourself in the chat. If you will include your name, your role, and whether or not this is your first echo session. And thank you, Anastasia. She's our contact if you have any kind of technical issues. And it looks like I see maybe one person, Anastasia, correct me if I'm wrong, that joined by phone ending in a 031. If you want to let us know your name, we can make sure to record that so you can have credit for today's session. It's an 865 number if that helps. Did anyone call in using the phone?
Mia, I believe it's Amy with Walgreens. She commented in the chat.
Oh, I see it. Thank you, Melissa. Perfect. Thank you, Amy. So you're on here twice. Perfect. That works out. Thanks. And then making sure that you are registered for this session. You can see the link and QR code there on the screen, and we can drop it in the chat as well. Oh, Clover beat me to it. So thank you. But if you make sure that you're registered for this session, that's going to help ensure that you get the appropriate credit to continuing education if you're interested and be able to participate in giving feedback as well. Next slide. Please turn on your video and mute yourself unless you are speaking. But feel free to come off of mute to ask any questions that you might have and participate throughout the presentations today as well. Please never discuss PHI, and of course, treat everyone with respect. And so that brings us to our case presentation, or didactic rather. So Dr. Allen, I see you on here. I will go ahead and pass it off to you.
Thanks, Mia, for the introduction. So yeah, like she said, we're going to talk about hepatitis C treatment specifically in patients who will have a history or currently using substance abuse such as drugs and or alcohol. Next slide. I first want to start off by saying I don't have any conflicts of interest discussing this topic, but I do want to disclose primarily I'm an expert in hepatitis C. My experience with hepatitis C and substance abuse is only in the space that I've seen patients through my clinical practice. The slides are not all-inclusive for all aspects of substance abuse disorders, so I just want to make that aware that it's from my experience and review of the current literature of what I have to present today. So feel free to chime in at the end of my presentation to kind of talk about patients or what your experience has been in this space with substance abuse patients. Next slide. First, I want to start off with some abbreviations. Of course, hepatitis C is going to be defined as HCV. People who use injection drugs, substance abuse disorder, alcohol use disorder, want to make sure we have those abbreviations defined, and as well as ones that you've seen before, the HCC and SVR12 that we're all familiar with, the cure determination. Next slide. We also want to further start off by defining objectives for this session. We want to discuss epidemiology of hepatitis C in substance abuse patients. We want to recognize risk factors that are associated with hepatitis C and what is not. We want to define what is the relationship between hepatitis C and alcohol. That's kind of the one that I went down a rabbit hole figuring out. We want to explain barriers of treatment with patients who have substance use disorders. And we also want to look at harm reduction strategies in those patients and that patient population to kind of help them, empower them for the future, and also educate them on risk of reinfections. Next slide. We want to first start off with epidemiology. We'll go on to the next slide. First, we want to look at the prevalence of hepatitis C in patients who use drugs and alcohol. There's not any national or nationwide studies that currently show hepatitis C positivity in association with patients with substance abuse history. Only regional and local data is present. I looked at many different sources, couldn't really find anything nationwide, but what I did find is about 53% of the population that are people who use injection drug use. About 53% of those patients will have hepatitis C or be exposed to hepatitis C. This varies widely. Found as little as 38% of patients who use injection drugs have a potential risk of being exposed to hepatitis C, as large as 68, even up to 90 in certain studies. So very wide range of percentages. So all the more reason to screen all of your patients who you know have a history of substance abuse, whether it be with illicit substances and also alcohol. And of those patients who were exposed to hepatitis C, about 45 to 85% based on the studies show that they will develop chronic hepatitis C. That means that not all patients who are exposed, even if they're participating in injection drug use, some will clear it on their own and not need treatment. So there is still that potential chance, just like patients who do not use injection drugs. So I want to make that clear that we should not treat them any differently. They still have the same chance of cure, and they still have the same chance of clearing the virus before needing that intervention. We just want to make sure we're treating them the same and not having or reducing any stigmas that are associated with those social histories. And then we want to look at excessive alcohol consumption. It leads to an increased risk of hepatitis C. We'll talk about that further on a coming up slide because there's more to look into what's actually causing that. And then, of course, as I just said, cure rates are the same, whether they are an injection drug user, they are a heavy alcohol use abuser, cure rates are the same. So we want to always initiate and start treatment as soon as the patient's ready to get that process rolling just because of better overall outcomes for that patient population, just as any other patient population. Next slide. We want to look at risk factors. This is going to be more of a review, but what we will see is there's one thing that we want to specify on the risk factors. Next slide. So we'll go through the list. Illicit drug substance use is the most common way to being exposed to hepatitis C, as well as non-steroidal tattoos, mainly happening in the prison system, sexual intercourse, sharing razors or toothbrushes, vertical transmission from mother to child, accidental needle sticks in the healthcare setting, as well as if they received blood products before 1992, those are potential risk factors. So I want to kind of open it up for just a second. What is missing as far as a risk factor of how you can be exposed to hepatitis C related to this session? Feel free to come off mute if you want to, or you can put it in the chat. See if I got any takers. If not, I'll go ahead and spoil the answer. The answer is alcohol. Alcohol is not a specific risk factor for hepatitis C. There's not a way that's been shown in any literature that you can drink alcohol and somehow get hepatitis C virus. So why is there such a correlation with hepatitis C and alcohol? And that's the question we want to answer. So let's go to the next slide and kind of look at that further. So the correlation between hepatitis C and alcohol, we want to make sure we first define terms. Hepatitis in itself just means inflammation of the liver. Now that There's also a virus that we talk about during these sessions, hepatitis C virus, which means there's a virus that is causing inflammation of the liver. That does not mean there's not other reasons or ways that there can be inflammation of the liver, such as with alcohol. Alcohol can independently cause alcohol or cause inflammation of the liver with overconsumption of alcohol. So that's what we want to make sure we're defining and distinguishing, that there are different ways of causing liver inflammation besides just hepatitis C. So alcoholic hepatitis, and then there's all the different versions of the hepatitis C virus. There's also other causes as well that's not related to the scope of this session. Well, we did notice that alcoholic hepatitis can lead to liver cirrhosis and hepatocellular carcinoma independently of hepatitis C. So patients who have alcohol use disorder as well as hepatitis C means they're at an increased risk of developing liver cirrhosis and liver cancer at a faster rate. So just think of it, they're kind of stacking on top of each other. The risk associated with both, they can stack and cause it to be at a kind of a expedited risk of developing it quicker. So we want to make sure we know those patients, know their histories, and kind of triage them accordingly, knowing their risk of developing cirrhosis is potentially faster than other patients without those dual risk factors. Heavy consumption of alcohol has been associated with 3 to 30 times more likely to have hepatitis C. That's based on a systematic review of about 133 publications. They showed this prevalence. So what is actually causing the alcohol being associated with hepatitis C? So I looked at the National Institute of Alcohol Abuse and Alcoholism, read a lot of different things, trying to figure out what is the association. Spoiler alert, there is just suspected mechanism of action of what's occurring, but what the most common ones is they feel that there are, based on the alcohol consumption, there's a capacity to compromise the immune system, which would potentially lessen the immune system, therefore putting a patient more at risk of contracting the virus. And that also goes with the potential that alcohol use enhances the acquisition of HIV or hepatitis C after the exposure to the virus, which kind of goes along the lines of what other kind of social things are they participating in with this overconsumption of alcohol. So there's not a real firm reason of how alcohol is associated, but the data shows that there is a correlation there, whether it be the other social aspects that the patient's participating in, or there's also a reduced immune system function potentially if a patient is exposed to hepatitis C through other risk factors that we just listed, and that kind of sets them up to be at a more likely to be contracted with the virus. Next slide. So we want to first start off by, when we initially see patients in the clinic, we want to have a pre-treatment assessment. Next slide. And that will go along the lines of knowing your patients, knowing their social history, knowing what they've been exposed to, knowing what they're currently doing. We also want to know if they're currently still using or if it's been in their past. We want to know how much. We want to know how much severity has been caused to their liver by their potential substance uses in the past. So like we said before, there is an increased risk of developing cirrhosis and hepatocellular carcinoma in patients who use injection drugs and alcohol use disorder. The faster you treat them, the better the overall outcome. It doesn't mean you have to treat them faster than other patients, just knowing that we don't want to put barriers in place, trying to slow down treatment, feel like we have to kind of have a 5-step plan or something like that to get patients to where they're ready to start treatment, because the data shows that there's better overall health outcomes if you go ahead and just treat them like you would another normal patient, but do educate those patients on their risk factors and continued risk factors of reinfection. Those are main things that we want to make sure we're educating on when we first initially see a patient. Now, identifying barriers to treatment. There can be, which we'll discuss on the next slide, there will be things that we need to hurdle, but we need to keep that in mind, that we want to treat them as other patients and just help them hurdle those barriers or get through them. Counseling on reinfection is also important, as well as counseling on harmful effects of excessive alcohol consumption. As we discussed, alcohol in itself, independently of hepatitis C, can cause liver injury. We want to make sure we're educating patients to dial back the amount of alcohol while they're on treatment. I get a lot of questions about, does alcohol consumption, is it going to cause any issue with the medication once I start? And I always tell the patient, all things in moderation. I want to figure out where they're at right now and try to limit their amount, because I tell them that we don't want to be causing liver injury by having binge drinking episodes while we're trying to cure the liver hepatitis C. I try to frame it in that type of standpoint to let them know it's not going to directly interact with the medication, but I do want them to know we're trying to make the liver healthier, and lifestyle changes like reducing the amount of alcohol can go a long way to furthering liver health outcomes as well. Want to build trust in those patients. Starting off, baby steps. It doesn't have to be big steps, especially in the primary care setting. When you're seeing patients more than I do, you can really build that relationship. And then once you've screened a patient and find that they have hepatitis C, you've already got that relationship built. And there's just a new challenge that we need to kind of work toward overcoming, and then be able to tell them they're cured at the end. It's a great thing. Next slide. Now, these are the barriers that I have found based on literature and based on current experience in my clinic setting of what can be barriers for patients who use injection drug use and or have alcohol use disorder. Social factors, one of the more important things that a lot of patients have to overcome, could be poverty, could be homelessness, could be addiction of a different substance, not just what we're talking about. Could be mental health disorders, could be a phone. Some patients don't have phones. I can think of a patient right now that he is currently on medicine. He does not have a phone. He does not have a stable address. But I told him, I said, if you will stay with me and you come to your appointments on time, I will get you through the medicine and you will get cured, and we will have those results for you when you come back. So what we did, we had an initial visit, and then we had a follow-up visit in about 6 weeks that allowed me time to get the medication approved through patient assistance. And he came back. I counseled him in clinic, gave him his first bottle, and then he did return 4 weeks later to get his second bottle. Great news to know that even if I don't have any way to communicate with him, he bought in, he listened to what I had to say, he trusted me, and we will hopefully get a cure out of him by the end of it, and that will be next year. So always good to share that even if patients don't have that much, you can still work with them if they will work with you, and that's where you build trust. If both sides want to work toward the common goal, that's where you can really get through those barriers. Now, as far as adherence concerns, that is always going to be a barrier to any patient, not just patients with substance use disorders. That's always going to be something that I try to harp on the most, because it's only as effective as how often you take it. And that's what I tell every patient. If you want to get cured, you need to take this every day. And that's how I frame it, just to let them know that there is overall long-term goals of why we want to cure the hepatitis C, not just for right now. We want to protect the liver as much as we can, but therefore hopefully preventing cirrhosis from occurring, and therefore preventing liver cancer. And that's how I try to frame it for all patients. So treating them all the same is important. Now, provider lack of training with patients with injection drug use, that is something that's always going to be, there's going to be hesitancy there with providers that haven't seen it that often. And so that's where that can be a potential barrier of where they want the patient to go through several steps to kind of prove that they're going to take the medicine. I get that, but I don't have that luxury. I see patients one time, and if I can get them on the phone, or if I can get them to come back to clinic, I will take that as a sign of trust that they want to take the medicine and they want to get cured. And so that's where I do my best. If they show up to a clinic visit and they don't even have a phone or a home address, I feel like that's an initiative on in itself that they want to take care of this. And so I take that as kind of the first step, that they took the first step, and I want to make sure I meet them where they're at to get them the medicine as quick as I can, just like other patients, and get them on the right track to hopefully better their life in more ways than one. Payers restrictions, there can be several different ways that payers can restrict things for patients with substance use disorder history. There are payers that can have requirement of maybe 6 months sober, and some can even ask for documentation that they went through a rehabilitation program before they will approve the medicine. Some programs or some insurance companies have done away with that. TennCare and Mississippi Medicaid have done away with those rules. I believe Arkansas Medicaid still has their criteria in place for sobriety before they will approve medicine. They also have other restrictions as well. There are some commercial plans that will also have language in their prior authorization piece that they promote a sobriety for at least 3 to 6 months. Some will be lesser on that side, and they'll say, I'm trying to think of how they phrase it. They just ask for that there's counseling on abstinence from substance use and alcohol abuse while on the medicine. We do that, of course, with all our patients. We want to make sure we're treating all of them the same. So making sure you're aware of payer restrictions, that will just come with time. I can't give specifics on which insurance plan outside of the Medicaid plans, but there are some out there that will still ask for those sobriety restrictions for now. But that can always change in the future. They're always updating formularies each year, and you can always check on formularies at the beginning of the year to see if there's been a removal of that language of somebody in the past. I can think of a person right now that TennCare used to have this stipulation, and she was actively using fentanyl. She did not want to stop, and she didn't want to go to rehab. And so, unfortunately, we had to defer her because there was no way around it with her insurance company with TennCare. Once the restrictions were removed from their prioritization criteria, I reached out to her. It took her a minute to get back to me because I feel like I kind of messed up the trust, or I guess not really burned a bridge, but I didn't really follow through with what I said I was going to do when we initially saw her, because the other piece to her story is she actually knew a patient that came to my clinic already, and she was frustrated when I had to defer her because of her substance use history, because she brought up a name. And I couldn't acknowledge that I knew the person because for HIPAA reasons, but she gave me a name and she said, how did he get treated? And I can't. And I had to just phrase it as patients have different insurance or payer sources that allow different restrictions or stipulations. And he was not one of those. He was a self-pay patient. We didn't have restrictions on him. And I kind of just had to leave it at that. She did not like that answer, of course, but eventually she did come back to clinic, and she is through the medicine. We're still waiting for her to come back for her SVR 12. She might have moved to a different state, so I don't know if I'll ever get that information, but just knowing that I did make an impact in her, reaching back out, she thanked me so much that I came back to her. Even it was 6 or so months later, but she really appreciated that, and she did take the medicine correctly once she was finally on the medicine. So I always want to share, even though it's a small patient case story, I do want to share that as far as an example of this for payer restrictions. Next slide. Now, next, we want to kind of transition to harm reduction strategies for patients who have substance use disorders. Now, these are kind of more generic, but I do want to make sure that you kind of think about these things when you're talking to patients with substance use history, engaging them with life-saving tools, and that includes talking about the risk and of continuing their current habits if they're still on current habits, and also promoting needle exchange programs, using safe needles, potential of reinfection, avoiding those type of things. Always want to make sure they're aware of those type of things, as well as providing information to create positive change in their life. Because the greatest thing about hepatitis C is that I feel like I can take something off their plate, and then hopefully that will push them and take another right step toward kind of bettering their lifestyle, bettering their habits, things like that. So I always feel like it's one thing that I can do to help them is to get the medicine, get them cured, and that way they can take the next step after that, after they've left my clinic. Making sure that they're have healthy, self-directed purposes, have goals outside of clinic. Once they leave, you can talk to them about that. Depending on how open they are, most patients don't want to talk about outside things, but every now and then I'll have a patient to engage me on other things they can be doing to improve their health. We can refer them to primary care here at our facility. So that's also something that we can help get other disease states under control as well. And that's just kind of goes with how the conversation goes and what they're open to discussing. We also want to make them aware to prevent overdose and other transmission of infectious disease potential if they're still going to be actively using. And that goes back to wanting to make sure that they're using clean needles and not sharing needles. And that's where those risks come in. And then as far as the last point, offering lower barrier options to accessing healthcare, and that includes substance use disorder treatment and also mental health treatment. talking about those things, if you see those during your interview process, if they need help that it's kind of outside your jurisdiction or outside your scope, making sure that you find a way to get them to the help they need, because most patients won't know where to go. They have made one step to come to you, and I do my best to triage if they need to go to another specialist and find that for them and get that appointment for them to kind of help them get to the next step. And those are things that anybody can do. It all depends on your scope. If you're comfortable doing those counseling points, go for it. But if you're not, do find somebody and have that contact, because if you're in this space for long in hepatitis C treatment, you're going to run across patients who have either a history of substance abuse or a current use disorder. So just be aware of those potential conversations to be had in the future. Next slide. And so now we can talk about risk of reinfection, as we've already harped on already. We want to make sure we're counseling them before treatment, during treatment, and after treatment, of course, to let them know there is a risk. Now, we've talked about, and that's why some payers don't want to pay and they'll put those restrictions up, is because they don't want to get patients to get reinfected and then have to pay for the treatment again. I see it as there's data out there to show that patients are less likely to get reinfected versus them being able to give hepatitis C to somebody else. So there is data to reflect that risk of reinfection is not as high as that patient actively having hepatitis C passing it on to somebody else. So I'm going to always be a proponent of treating patients, even if they're currently using, because I know there's a less risk of reinfection in those patients. But we also want to make sure we're promoting lifestyle changes to also prevent reinfection in those patients who are still currently using. So we've got websites here posted for syringe service programs. That way you can help direct that patient to where to go, because like I said before, patients will not know where to go. And so it's good for you to have those things in place already to be able to share to them. I'm like, if this is something you want to do and participate in, this is kind of where you can go to participate in that. Patients will also have questions about where to go for drug rehab. I've been in communication with several of the institutions around Memphis, so I've become accustomed to know who they are and what their phone number is, and I can supply that to the patient, whether they need a referral or they can just self-referral. I've learned those rules along the way, and that'll kind of come with just experience in your space and your area of where there are drug rehab programs in your area. And then as far as other risk factors to avoid reinfection, we want to make sure we're counseling on all the risk factors. So that includes the non-steroidal tattoos, the sharing of razor toothbrushes, the personal hygiene products, and things like that. And sexual partners, you don't know their status. I try to make sure I make them aware of that if you don't know their status, safe sex practices, and things of that nature. Just making sure that those are other potential ways that you could get reinfected, even if you're using clean needles, making sure they're aware of all the potential risk factors. Next slide. And this is kind of a wrap up of being the change, being the first step for these patients. I've seen it time and time again that they will be patients with a substance abuse history or currently using. They're usually not very welcoming, not very wanting to be here. But what I will notice is that they came to the appointment. So that means that they care something about it, unless somebody forced them to be there. So building that trust is the most important thing, letting them know why you care so much about treating hepatitis C, being aware of their social history. I want to make sure we are aware of it, but we don't want to treat them any different. We don't want to put up self-imposed barriers. We still want to treat them as quick as we can, knowing that the overall health outcomes are greater if we go ahead and treat them now versus trying to wait and take care of some things first. Compliance is always going to be a concern, and we will talk more about patients who maybe have incomplete treatments. I believe that's going to be coming up soon, so that'll be something that we'll be looking forward to, of patients who maybe fall off the map and aren't able to be contacted, but they didn't finish a full treatment course. How do we treat those patients if they do return? So that'll be something to look forward to. Helping patients hurdle or remove barriers, that goes a long way of building that trust. If you can help them get over things that they've been trying to figure out, or where to go or who to talk to, specifically with hepatitis C, getting the medicine goes a long way. But patients come to me, they know that medication costs a lot of money. And for me to be able to tell them that they can get it for free, whether they have insurance or not, some insurance companies might be a $5 copay, but for the most part, I can get it to them for free. That's really impactful for them to know that there's somebody who's here to help them, and that it really kind of solidifies that I'm on the good side, and I'm here to help them. As far as promoting healthy lifestyle habits, that'll be as same as before. Preventing risk of reinfection. We don't want them to come back and see us, and that's usually what I try to tell them at the end. I tell them they were a great patient if they took their medicine right, and it's kind of a so long for now, and just letting them know that it's okay to not come back and see me, even though some patients still like to call me and ask for other help with other things, and that will happen, and that just lets me know that I made an impact in their life enough for them to continue to reach out to me for questions they might have about their health. And of course, making sure that they come back for their SVR12 is the most important thing. That way we can tell them for sure that they're confirmed cured, having that information. Some patients will ask me for letters. That way they can know and just have it in their hand that they know that they're cured. And if they need to give it a different physician that they see, outside primary care doctor, something like that, they can provide that information as well. So always just being a patient advocate for them, same as you would for any other patient. It really goes a long way to kind of breaking through any type of stigma there might be around patients who use substances or have alcohol use disorder. With that, I'll open it up for questions.
So feel free to come off of mute or drop things in the chat if you have questions. I know I feel like harm reduction strategies and this topic is something we could probably talk about all day and have a training all of its own. There are so many pieces to it. I really appreciate, a lot of the things that you highlighted and kind of patient stories too. And I would love to hear what others have known and seen in their practices and kind of what your approach is to. I do see one question, I think, Lila.
Okay, I had a question. Like, what do you tell your patients that come in and you know that they're actively using IV drugs, and they tell you, because I've talked to some as a navigator, getting them into, linking them to care, and they tell me, like I talked to somebody just the other day who said, well, I go to an SSP, but sometimes when I don't have any, my partner and I share, and or they share with whichever drug partner is available at the time, and and so it's kind of like, well, are they reinfecting themselves while they're taking the treatment, or how do you go about that?
That is a tough question. I don't think I've ever had somebody tell me that specific story. I'm trying to think of the main thing I can do is just remind them that the best practice is. And as far as I might defer to Dr. Chastain about potentially reinfecting themselves while they're on medicine, that might be a little past me. But just reminding them of what is the preferred option of using sterile needles, not sharing, and just trying to reinforce that's the preferred method, even though, and just trying to prevent them to break those habits of wanting to share, even if they don't have the preferred sterile needle at that specific time. Just trying to remind them that's something that they need to trying to fight off that desire. I know that's easier said than done for these patients, but that's something that I remind people of. I had a patient, this is a kind of a tangent, but a patient texted me and said that, hey, I didn't take my medicine to the hospital and I've missed 2 days. And he's like, what do I do? And I said, when you get home, I want you to take your dose, and I want you to make sure you're always bringing it to your hospital visits. If you have trouble breathing and you have to go to the emergency room, you need to bring your medicine to you. That way you don't miss any more doses. So it's not like I can change what just happened, but it's more of just trying to reinforce for the future is how I try to phrase it. And we would just kind of check a viral load, of course, when they come back to clinic, and just kind of go from there as far as assessing if there was a reinfection or something like that. I'll see what Dr. Chastain has to say.
Well, and I did, talk to them, reinforce again, and I gave her the safer injection guide that, is from the health department or the state, and that shows them how to clean syringes and things like that. But it's kind of like, don't do that.
Yeah, so these are tough situations. And I think the reality is that many people that we are caring for who are struggling with substance use or struggling with substance use disorders is that there might be behaviors that put people at risk, whether they're on treatment or subsequent to treatment. Ultimately, I think the best thing we can do is to treat them, to offer them the best resources and services. The likelihood of reinfection while on antiviral therapy is quite low, but we don't have a lot of data in that regard. We just can extrapolate that from other antiviral used for other viral diseases. Ultimately, though, I think that looking forward, if someone is struggling with safe practices, that may make it extrapolating. If they're using while on therapy, that might mean that there might be other exposures subsequent to completing therapy prior to the time that we can assess for cure or a sustained virologic response. Ultimately, this is still the right thing to do for that individual person's health. It's the right thing to do from a public health standpoint because it will reduce the risk of transmission to that other partner or partners that they might be sharing paraphernalia with. And ultimately, I don't think that we should extend judgment or approach these therapies differently than what we would potentially with sexual health or other public health-oriented infections. So, for instance, chlamydia or gonorrhea or another sexually transmitted infection, we don't choose not to treat those when patients have ongoing behaviors that might lead to reinfection. The difference is in the context of these therapies is that there is additional cost and complexity of accessing the therapy, but it ultimately doesn't change the rationale for us to actually pursue what's best for that individual's health and also to care for our communities at a larger scope. I will say there was one question for Dorinda that mentioned, are there any increased risk for side effects from hepatitis C treatment in those using substances? What I would say is that to my knowledge, that there aren't a lot of specific overlaps here, but we do have to think about substance use as the same thing as medication co-administration. Substances are medications, or they are processed by the body, metabolized in the same way. And protease inhibitors can sometimes elevate exposure to opioids, depending on some of the medications. So there might be increased medication exposures just because of some of that cytochrome P450 inhibition. And so while we don't anticipate increased risks of side effects per se, there might be additional interactions, and Clark, I'll let you speak to that from your perspective.
Yeah, I'm kind of in agreement with that. I don't really have much more to add to that. You kind of explained it.
Awesome, thank you. And it looks like Caitlin, I see your hand up.
Hi, I just wanted to respond, is that if we know our patients are using drugs or sharing needles in networks, I think it can be really helpful in intake and like our pre-assessment to assess those networks and kind of see if we can enroll that entire network in care and kind of use like micro elimination strategies in these kind of like small social networks where people are sharing drug equipment. Thanks.
I would agree with that. I've had patients, not necessarily that's a great point to like assess about networks, but I've had patients that if I've done a good job, they have referred me to a friend that they know, maybe in their circle, maybe not. But I have had, if you will, referrals from friends that will then call me and say, hey, I want to be treated too because you said you had such and such on medicine and they got treated. So I've had those experiences, but yeah, that's a great point to kind of reach out to let them know on the front end if there's other patients with them that are currently using, to kind of just go ahead and initiate that and let them know that there can be treatment for them too.
Yeah, I think that is an excellent point. Lots of great questions here. And I did see another comment in the chat as well about, let's see, would we want to be sure to give them rescue Narcan with their treatment? Anyone else can go ahead and jump into. I would say that naloxone is certainly widely available, and it would be great to, and I see Dr. Chastain adding some comment in here, yeah, to encourage being able to have it and being prescribed. Let's see, to people with opioid use disorder, as well as people in contact with those who use opiates. And I completely agree. I'm going to drop another link in the chat, all kinds of links in the chat this time, guys, for regional overdose prevention specialists. These are individuals that work with the Tennessee Department of Mental Health and Substance Abuse Services, that are able to offer training related to naloxone and kind of get resources for large groups or individuals, and point people into resources. Of course, they can, you can prescribe it as well and such, but it is available over the counter, and this is a way for them to be shown how to use it and some training also. So a great resource, not only for those individuals that are actively using, but as Dr. Chastain said, for family members and those that might be around them too. It's honestly a great resource for anybody to have. I know a lot of our staff kind of just carry naloxone in general. So, but any other questions before we start to transition into our case presentation? Yeah, thanks, Anastasia. Great point. If you have questions specifically about the syringe services programs or harm reduction, you can reach out to our SSP team at ssp.health@tn.gov. That is an opportunity to become an SSP if you're interested in hosting one, but also learn more about harm reduction services that we are aware of at the state level, and we'd be happy to connect you to. There are some different resources. It's sometimes kind of hard to find them on all the different websites, but I did try to drop a few in the chat as well. I think oftentimes when we talk about harm reduction, we also talk about using person first language and trying to make sure that we're being, really careful with our wording and such as well. So I will drop that information in the chat too, but we will transition to our case presentation in the interest of time, but feel free to keep adding comments and questions to the chat as well.